So next we have clinical case seminar on diabetes in children. I request Dr. Krishnan Swaminathan to moderate the session, and also I invite Dr. K.M. Prasanna Kumar, Dr. P.G. Sundararaman, Dr. Santosh, and Dr. K. Ravi Kumar for discussion. Please come to the dais.
Kali Vanakangal. Good morning, everyone. I think this is a very important session. It's one session that's very close to all our hearts, diabetes in children. The way we have set up it has to be very interactive. So I need all of the audience to come forward to the mic. We have got a few set of questions as to what you would do in your practice if you get a clinical scenario. And we have got 4 fantastic experts here who have done quite a lot of work in diabetes in children to answer all your queries. So first of all, just a brief introduction of all the panelists here. Dr. Prasanna Kumar needs no introduction. He was a past president of the Endocrine Society of India. He's got a specific interest in diabetes in children. He's the chairman for Changing Diabetes Children program in India. We've got Dr. P.G. Sundararaman, who's a senior consultant in medical endocrinology in Apollo and Bill Roth Hospital in Chennai, and he has got multiple peer-reviewed publications to his credit. And we've got Santosh. I'm going a bit fast for the slides. Santosh, welcome from Hyderabad, and he's presently the director and consultant endocrinologist at Magna Clinics for Obesity, Diabetes, and Endocrinology, and he's also got a specific interest in pediatric diabetes. And last but not the least, we've got Dr. K. Ravi Kumar, who's a consultant pediatric endocrinologist and intensivist at Kanji Kamakodi Child Trust Hospital in Chennai. And a bit unusual to see this combination of pediatric endocrinology and intensive care. It would work really well for kids with diabetic ketoacidosis. Welcome to all the panelists. And the reason why I say is that about 3 days I had a case of a child who is sitting in front of me, just thirsty all the time, drinking loads of water, a 3-year-old kid. And amma vandu biscuit packet pakkathula vechirukanga, eating a lot of biscuits. And it took about 4 weeks to get the diagnosis. There are 3 issues that we are going to concentrate in this discussion today. One is diagnosis. And it's still surprising to see that a lot of kids are misdiagnosed initially, where the polyuria and polydipsia is not picked up in general practice. And by the time they come, they are in impending diabetic ketoacidosis. So sometimes எல்லாம் சரியாயிடுமா அப்படின இருமல் சளிக்கு கொடுக்காம and the polyuria polydipsia alarm bells should start ringing up. And number 2 is how do you manage it? And we do see a lot of general practitioners and non-specialists managing type 1 diabetes, and I think some of the questions are directed towards what the management issues are, especially in terms of insulins, oral agents in type 1 diabetes. And finally, counseling. Type 1 diabetes is not a condition where you just treat and ask the patient to go. It takes about 1 hour for you to counsel the family. It has long-term psychosocial implications for not only the patient but also the family. So I think with this background, we'll just go on to some of the few cases that I've seen in my practice recently. And this is the first case. And again, please feel brave today. Come up to the mic and see what you can say. This is a 12-year-old girl presenting with a 3-week history of polyuria and polydipsia with a random sugar of 386 and 4+ on the urine in terms of glucose. And can someone come up to the mic and say, what do you think is the working diagnosis? It may sound silly on the face of it, but I'm just trying to get at whether this is just diabetes or ketoacidosis, and it's mainly on the diagnosis aspect. Anyone? Someone to the mic? So you would think it's newly diagnosed diabetes, probably type 1, is what you're saying. Again, Rangaran sir, you did say you want more investigations. Anything in particular that you have in mind? You want blood ketones? Is it available?
One is ketone, another is C-peptide levels.
You want ketones, okay? And the final question is, how do you brand a diagnosis of a child having diabetic ketoacidosis? What is the diagnostic criteria? When would you say? that a kid, when do you brand this diagnosis? Because it's an important diagnosis. If you make the diagnosis, the child needs to be admitted to hospital. What are the criteria?
Only with the ABG you can do a diabetic ketoacidosis as a diagnosis.
With the ABG,
Yeah.
you would subject a child for an ABG to make a diagnosis. I think those are all very reasonable answers. Now we'll just go on to the panel. I think first I would request Dr. Prasanna Kumar to just go through this. And again, panelists, feel free to chip in. We have a lot of time. Dr. Prasanna Kumar, do you want to just get started?
Yeah, I think it's good we have interaction like this when a child comes with 386 and urine sugar 3+. First understanding is, yes sir, you are right, ABG. But you are in your clinic. It's not that child has walked into intensive care unit on a hospital. Yeah. So, no, the whole idea is every one of us is not working in a hospital. If you ask me, I've seen the last emergency 10 years back. Last ketoacidosis was 10 years back. I'm very happy because I have 1,200 children. My aim is no child dies with diabetes. No child is admitted with ketosis last 3 years, if we can give a good care. So the whole idea, as you said, if you're in a hospital ABG, but even before sending to the hospital, you have got a small clinic where you can do ketone.
Yeah, we can do the blood ketone as the same method as your urine ketone itself. It is still, instead of urine, you can use the same blood drop and you can just use the same test as can do a
Sir,
blood ketone.
where is that? Are you using it in your practice?
Yes, I think that is good.
In the periphery, when you want to ask a
Yes.
question, you can use. But we have a blood ketone strip also is available. If you want, you can use a blood ketone strip. But it's not available routine, not practiced by everybody. But in a small hospital, we can use the same methodology as your urine ketone. As a blood, instead of urine, you can put a blood ketone, but it may not be very quantitative.
Okay.
Yeah, basically, in a clinical setting where the patient comes to the clinic, that you assess clinically first. What is the clinical assessment that you're going to do in a case of a hurried respiration or altered sensorium or a dehydration, and what happened to the pulse and BP? These are the clinical settings that you're going to monitor. And you know very well, the diagnosis depends upon three important things, like hyperglycemia, acidemia, and ketonemia. So these are three important basic aspects that you're going to monitor. And it doesn't mean that the person is having ketoacidosis with this. We don't know. It's a case we can label as a diabetes mellitus. A diabetes mellitus can be a type 1 or type 2. It can be both. Now, both can present as the ketonemia. It can excrete ketosis. Now, how to differentiate between a type 1 and type 2 diabetes mellitus? That's where your laboratory parameters comes to.
Sure. Dr. Ravi Kumar, I think SD, while speaking, you said that you had a specific interest in misdiagnosis of diabetes in children. Could you just more explain your personal experience?
Yeah, that's right. Having worked in intensive care in a pediatric hospital, I've like a lot of these children get referred very late, and by the time they have altered sensorium and severe dehydration, a lot of them get treated. They don't. I mean, the diagnosis gets missed, and some of them get treated with antibiotics because they present with abdominal pain and vomiting. And a lot of them are seen by the surgeons first, who would start IV fluids and antibiotics instead of thinking about it in the mind. And sometimes they do a urine routine, which might have shown 1+ sugar or 2+. But often the blood sugar is not done concurrently and it gets missed. And in our experience, I would say about 70% of the children with type 1 diabetes actually get admitted to ICU because of severe DKA. And this older child perhaps may get diagnosed much earlier, but I'm talking about the younger ones. It's very common that they get delayed.
Sure. So, yeah, Dr. Singh.
In fact, I remember when I was in ICH, a person coming with asthma, my senior used to want to check the urine sugar. So asthmatic, before giving steroids. Usually in a general practice, they give steroids for acute asthmatic. In those conditions, we check for the urine sugar and urine ketones.
Sure. And Santosh, please, final call for you. If you just say, how do you brand a diagnosis of DKA, just to give some take-home points?
So in this case, the first thing that we have to, before branding a patient with type 1 diabetes, we need to be pretty sure. Okay, so it's not a given rule that a 12-year-old girl needs to present with type 1 diabetes all the time. So type DKA, as you know, it has certain clinical diagnostic criteria, but for this learned audience, we'll go for more of the biological criteria. It is a triad of hyperglycemia, it is a triad of ketonemia and acidosis. So we have certain criteria. Can we move on to the next slide?
Sure. I think just in a nutshell, to summarize the important take-home points here, please do think of diabetes in children, especially when they present with multiple symptoms like abdominal pain, asthma, generally unwell. And again, importantly for you to say that someone has got DKA, you need to tick 3 boxes: diabetes, ketosis, and acidosis. So for this child, the urine ketones are 1+. And just to throw up this question, because we did talk about blood ketones and urine ketones, what are the predominant ketone bodies in DKA? What does urine ketone positive mean? What does it measure? And does it happen in any other condition? Because sometimes I find a lot of patients being branded as DKA, given a lot of fluids, where they don't have acidosis on either the ABG or the venous bicarbonate. Are there any other better ways of identifying ketones other than urine tests? Anyone in the audience? Any doctors who have just finished their MBBS can better answer what are the other ketone bodies in DKA? Anyone here? Madam, நீங்க mic வாங்க. நீங்க நிறைய பதில் சொல்றீங்க. ஆனா mic வரணும் நீங்க.
So can I tell?
Beta hydroxybutyric
acid, acetone, acetoacetic acid.
Fantastic, sir. So I think those are the 3 ketone bodies. And what does urine measure? The ketones?
It's only acetone.
Acetate.
And
Yes,
acetate. And I'll just open it to the panel on using urine testing for ketones in DKA. Do you want to say, Dr. Ravi Kumar?
Again, with regard to the blood ketones, I want to make a point. It measures the acetone, and it's a very qualitative test. And 1+, 2+, 3+, it's sometimes not very accurate. Another point is in children who are ill, because of fasting, even without DKA, they can have ketones. And also stress hyperglycemia often can happen in this cohort of children, especially with high temperature, sepsis-like presentation, stress hyperglycemia, steroid-induced hyperglycemia. All these are differential diagnoses.
Sure. Dr. Sundararaman.
And also, you must be aware that in a hospital setting where blood ketone must be measured, and in fact, as we treat also, we find sometimes the urine ketones become negative, still the blood ketones being positive. So that doesn't mean that you're going to shift the treatment channel.
Dr. Prasanna Kumar, anything? Santosh?
So, I think given the present limitations, we have urine ketones, which measures the acetoacetate as the only surrogate marker that's available in our day-to-day practice. And that can be used as a diagnosis of insulin deficiency. But as here the panel recommends, that Varun says that there are many other causes of ketone bodies being positive as well. So we need to keep that in mind. But given the diagnosis of hyperglycemia with urine ketones positive, it may be, given the clinical condition, may have to go for an ABG as well.
Sure. Yeah.
I would like to make a comment that only just in a child it is known to have hyperglycemia, urinary ketones does not provide a diagnosis of diabetic ketoacidosis. That everybody should understand. Just because they are doing a urinary ketone and just if it is positive and there is hyperglycemia is there, please do not treat as diabetic ketoacidosis.
That is diabetic ketosis.
Yeah.
Acidosis is still not come.
Sure.
So,
and I think that's a very important point. So if you don't have measures to do ABG, at least do a venous bicarbonate. I think that will give us a lot of, and even venous pH is good enough generally. And I think if I may add a point, and panelists correct me if I'm wrong, at least in the UK we have blood ketone testing which measures beta hydroxybutyrate, which is the predominant ketone body in DKA. And you get a direct measurement. I don't know whether you have beta hydroxybutyrate, you've got it here, is it?
Keto sticks that we use in our hospital measures only acetone.
Acetone.
Yeah.
So it's not a good measure. And the other important point I want to make is that as you treat DKA, the beta hydroxybutyrate gets converted to acetoacetate. So sometimes what you can see is as you treat DKA, the urine acetone will be more strongly positive. And that doesn't mean that the child is not getting any better. It means that everything is getting flushed out and the beta hydroxybutyrate levels are coming down. So, and the other important point is urine ketones can be positive in fasting, starvation, vomiting, and a lot of other conditions. So You have the facility to do both a bicarbonate and a ABG. The blood gas shows a pH of 7.36. Venous bicarbonate is 21. I want to ask someone in the audience, if this child comes to you, how do you propose to manage this child? How many in the audience are comfortable managing this child, or how many would you like to refer to a specialist?
So this patient, I cannot label as diabetic ketoacidosis because you are having this, already told that bicarbonate should be less than 15 milliequivalent, pH should be less 7.3, and also blood sugar should be more than 250. That is the criteria.
Sure.
Is that any patient is having blood sugar more than 250, you are having that pH 7.3, bicarbonate less than 15, I can call this patient is having diabetic ketoacidosis.
Sure. So there's not DKE.
DKE.
Would you, could you introduce yourself as to what you're doing? Are you a hospital practitioner or a general practitioner?
Sir, this patient we have to find out what
No,
is the
sorry,
correct.
I'm asking you, do you practice in a hospital or?
Sorry, I'm one of the professor
Oh, sorry,
in
sir.
SRM Medical College.
I didn't realize
And
that.
also,
Yeah.
I am with the intensive care unit. I am taking care of adult.
That's
So
very
that we
useful
are
to
seeing
know,
many
sir.
cases there.
Thank you very
So
much.
that
Sir.
is-
Thank you.
thank you.
Is there any sort of general practitioner in the audience who would see such a case and tell me what they would do if you're going to use insulin or manage this child? How do you do? Or at least if you think that this is an area that I'm uncomfortable with and refer to a specialist, how many of you would do that? No? So, right, we'll just throw it to the panel here. How do you propose to manage this child? Dr. Prasanna Kumar, do you want to get started?
As I said, last 10 years I don't admit any patients. And you see this patient 8 o'clock in the evening when they are about to leave. And you tell them it may be ideal to get admitted to the hospital because you may need further investigation and all. Patient refuses. If the patient agrees, as you said, fine. We have got pediatric endocrinologist, please go to that hospital. I don't think it's the right time to start treating. It will take 1 hour to educate the child, 3 days to educate the mother, and they are in a shock. So ideal situation is to refer the patient to a hospital where specialist care is available, and it is their duty. They will admit them, assess everything, and then treat. But every situation is not ideal. Patient refuses to go to a hospital. It is 8 o'clock in the evening. And you have got maybe half an hour, 1 hour at 8 p.m. Still you have to get an insulin, start insulin for this patient. And patient says, I will not get admitted. How do I manage outpatient? Why I changed this case, what Swaminathan has put in the past, was a patient with ketosis, small breathing, acidotic. I think out of 150, 250 people here, not even 10 or 20 of you have seen this ketosis treating. Most of us are outpatient doctors. I was a professor 30 years, but last 5 years I'm outpatient management. So when you see such a case, all right, patient refuses admission. I always write, because something happens to this patient, they will blame. So I always write this, patient refused admission. But still you cannot say, if you are not getting admitted, get out, I will not treat you. It's nonsense, you cannot treat that. I said, fine, this is the situation. Get a insulin pen or vial, whatever it is, start regular insulin. You have a glucometer, fine, you have got meter, otherwise give him glucometer 20 strips. Please check blood sugar 3 times a day, because you are not in such a serious condition, there is no dehydration or anything. 3 times a day do blood sugar. Sir, how do I contact? Can I call you every hour, every 2 hours? No, not possible, no problem. You can SMS to me every 2 hours, anytime my phone is on. You can send an email also, because these patients, I have many of them who walk to my clinic 300, 400 type 1 diabetic child. The first thing is to refer to hospital. Refusing it, I have treated many of them, including income tax commissioner, son, daughter, whatever it is. They manage well within 5 days. Every day they are sending blood sugar management. Why I am trying to tell you, if the patient was admitted in a hospital, even for a poor patient, it may cost 30,000 to 2 lakhs. Next 5 years, he will be paying it. What is it that you are doing there? 3 times a day giving insulin, 3 times a day you are doing blood sugar. Doctor signs off morning, afternoon, night, and all that. And the burden will be maybe 5 years. So I feel clinically when you assess it's not, I'll still manage this patient. But if the patient refuses admission, I'll write patient refused admission, because it may be a legal problem. Same thing holds good if the patient refuses insulin, type 1 or type 2. I'll say, I will write here patient refused insulin. Sir, don't write like that, I will take insulin. Because the moment I tell him, I'm going to write here patient, because if this patient goes to him and says, I think Prasanna Kumar is a quack practicing in Bangalore, and he didn't start insulin. He is a quack, he did not advise admission to hospital. Blood sugar is 380, ketone body is 1 plus. Whatever the situation, you can't. So that's why it is better to mention there, and still patient refers insulin admission, we have our duty to see. Now we have got distinct management of the patient. By this, all my 1,500, 2,000 patients are on email contact every day. Wherever in the world I am, after all, many people in this hall may disagree. Diabetes is a disease of numbers. Numbers of blood, HbA1c or blood sugar. What you have to do, not a rocket technology, unless in emergency. You see the blood sugar every day, 3 doses, whether increase 2 units or 4 units. In any time, patient will be better controlled. That's how we'll still manage him as outpatient.
Thank you very much. And not sounding too selfish as endocrinologists, we would say, if you're not comfortable managing or not had the experience of managing high sugars in pediatric population, please just refer to a specialist. It needs a lot of time and input, as Dr. Prasanna Kumar said. I'm just giving a different scenario here. Glucose of 386 with urine ketones of 4 plus, a bicarbonate of 12 with pH of 7.16. As Sir rightly pointed out, this all fits in with the diagnosis of diabetic ketoacidosis. Glucose is high, ketones positive, and acidosis is there. Would you manage this child differently, and how? And I think this is just a no-brainer. It's just to give a feel of what you would do. This child really needs an admission. Dr. Ravi Kumar, I'm going to touch upon DKA when we come to that. Now, as Dr. Prasanna Kumar said, I was wanting to ask the question, but he told what happens in practice. Family not keen on admission, and dad is not keen on insulin. Sir, எப்படியே மாத்திரையை ட்ரை பண்ணுங்க சார், என் குழந்தைக்கு இன்சுலின் வேண்டாம். And ஒரு வாரத்தில் வந்து பார்க்குறேன். What do you do? Is it worth trying oral agents? Definite no from the entire audience, which just brings to what are the differential diagnosis of hyperglycemia in a 12-year-old. So can I just, Dr. Sundaraman, do you want to start on what are the other types of diabetes that can present in a young child? We shouldn't be focused just on type 1 because a lot of other conditions can present with hyperglycemia in a young child. And would treatment be any different if it was other types of diabetes?
I just want to throw a question to the audience that now in the field now we have the facility of the proteomics, the molecular study, and various other things. Now, how are we going to be sure that this person is having a type 1 or other form of diabetes?
I think that's a great question.
Can the audience can respond to this?
Please, can any one of Madam, you want to stand up and tell how do you make a diagnosis of type 1? Come to the mic, introduce yourself. ஒரே நிமிஷம் ராமநாதன் சார், நான் அடுத்தது சொல்றீங்களா? அப்படியே வாங்களா?
So I'm Dr. Ramya, postgraduate student.
Sure.
This can be 2 other alternative diagnoses also apart from type 1. The first one, we should see the general physique of the child also. It can be an early type 2 diabetes also, since it is on rising trend. And the second possibility, with the family history's help, we can even check for the possibility of an MODY, maturity onset. Since the onset is less than 25 years, we can see the serial generation family history. So these 2 other can be possible.
Have you finished your MD or you're doing it?
Sir, I'm postgraduate student.
You're a student. I'll ask your professor to give you a pass. Fantastic answer.
Thank you.
Good. Ramanathan sir, do you want to, I think there's a fantastic answer. Just impressing on the fact that we shouldn't be focused on type 1. There are other types of diabetes you can manage with oral agents if you feel that it could be a possibility.
2 more different.
Lila. Not in a DKA, sir. I'm just saying just hyperglycemia, no DKA.
No DKA.
No, not with that patient. I'm just generally saying think about other conditions. Yeah.
So 2 more differential diagnoses I wish to offer, sir. One is fibrocalcific pancreatic diabetes.
Fantastic, yeah.
Another one is a malnutrition-related diabetes mellitus, which is somehow, they may not be very common, but in a patient with 12 years old, we have to think about it. And it's better to take an abdominal X-ray and abdominal ultrasonogram and see whether the pancreatitis is okay or not in this patient. It's not a DKA case also.
Sir, there is no diabetes in the world which you can't say can't develop DKA. Even type 2
this
can
patient has not
DKA.
developed a DKA also. So it's better to see. Suppose the patient is very lean and the patient is having some difficulty.
Madam, please. Good point, Dr. Ramanathan. Madam, come to the mic, madam, please. We can't hear you. Sir, in terms of pancreatic diabetes and DKA, I'll ask the expert panel to address that.
I'm Dr. Saroja and I work in the diabetes department of VHS. How about estimating the C-peptide for the patient to make
But
a
the
diagnosis?
main problem with C-peptides would be the assay capability, financial thing. So that's a good point. I'll leave it to the panel to discuss. Santosh, do you want to get started as to other types of diabetes and how you diagnose?
See, the other type of diagnosis, now at the OPD, at the outpatient department, you would like to see whether the patient, what is the signs of, there are any signs of insulin resistance, what is his body mass index, what is his family history. If you're able to chart it down quickly, then you'll be able to make a diagnosis of type 2 diabetes. MODI will also be picked up by a strong family history of earlier and earlier onset of diabetes. I think the strong question over here is, here you have a person who has high blood glucose and is having ketosis. So even if the diagnosis is any other type of diabetes, would the treatment be any different? So if it is a type 2 diabetes is present with high blood glucose and ketosis, would we be treating him any differently at this particular moment today?
Sure. No, I totally take the point. If ketones are positive, it's a different scenario. But what I wanted the audience was to see if the glucose is 220, no ketones, just to improve their understanding of different types of diabetes. But I totally agree in terms of relevance to this case, you would treat with insulin anyway is the point you're trying to make. Yeah.
As the audience has interacted, there are other forms of diabetes. See, there's a condition where there's no decay present. And like you have got the MODI type, you've got the atypical diabetes, or I was just trained under Professor Ahuja. He was very familiar with the malnutrition-related diabetes mellitus.
Is that entity still there?
It is not there. No. I'm just telling you the earlier. In all these situations where it depends upon the severity of hyperglycemia and what are the other precipitating events and what are the other molecular basis of these things. And this can present in various ways. And in all forms, you can develop ketosis. It is not acidosis, but ketosis can be present with the coexisting phenomena. What do you think, the other panelists?
Yes, sir. My practical experience, we see more stress hyperglycemia. I think I want to emphasize that again. In any situation where there's a high temperature, sepsis-like presentation, that has to be borne in mind. Other thing, I think C-peptide, GAD antibodies, islet cell antibodies, all these are available nowadays, and we all do them. But end of the day, if you've got all the results in front of you, still it becomes difficult to decide whether they're type 1 or type 2.
Yeah. I think the important take-home points is please assess the phenotype of the GERD, and please ask for a strong family history. And any acutely unwell patient with hyperglycemia, don't brand as type 1 or anything till the acute condition resolves and you have better ideas. So parents finally... Mike is running, sir.
Just the presence of ketones does not brand the person as a clinical entity of diabetic ketoacidosis. If the patient is able to take food, conscious, oriented, and normal, the acetone may linger for some more time after your correction because it gets fixed with your body fat and gets slowly released. So the very presence of ketone does not brand them as a diabetic ketosis. As per your pancreatic diabetes, we are not talking about malnutrition-related diabetes now. We are talking about pancreatic diabetes. In pancreatic diabetes, there is a basal insulin available. And the fat mass available for the conversion from the lipid to the ketones is very less. So normally in a clinical situation, even though they mimic the presence of a type 1 diabetes, a lean child coming, all these things, but usually the differentiation point is the presence of ketoacidosis. That's what I want to tell.
Sure.
And to Prasanna Kumar, I would like to tell you one thing, sir. The availability of insulin, people taking insulin, is irrelevant to this state because from 1998, Tamil Nadu government is giving insulin free of cost for 28 days for the children to get themselves administered in their houses because we have convinced the government that they can take and monitor the dosage. The storage of insulin does not require a fridge. All these things have been told and we have successful here for the first 14 years or 15 years. There is not even a single death of decay due to death of insulin in our state. And the monitoring and all, we can educate the people and it's not possible you can have communication, etc. Otherwise, if we take a bit of strain of explaining and training the person, it's quite successful here.
Sure. Thank you very much, sir. But for want of time, we'll keep, quick
Somebody
points.
started the argument on C-peptide. I would like to ask a question. What is the temperature stability of the C-peptide test? Whether, because I have read as C-peptide is highly temperature unstable in the laboratory, the test. Whether the blood can be taken, can be transported normally to a different center till the time they will be stable or not.
Dr. Prasanna Kumar, do you want to?
See, C-peptide is quite stable, unlike insulin. Second thing is important question here is, don't check C-peptide when the patient has come in ketosis 285. Don't bother about it at all. First, treat, as Santosh said, treat diabetes, achieve euglycemia. I will check C-peptide maybe after 1 month or 2 months when the fasting blood sugar is good, because when the blood sugar is 360, 400, checking C-peptide has no meaning. And it is quite stable. Draw the blood, separate the serum. You can keep it in fridge days together, -20 for years together, and it is quite stable and quite reliable if you can do C-peptide. You don't have to worry.
Thank you. Sundar is giving me the look of the time. We've got a few more to discuss. Would you go for twice daily premix or basal insulin? Which one would you go in a school-going child? What are the pros and cons for each in such a patient? Anyone in the audience? Ideally speaking, we are all told the basal bolus 4 times is much better in terms of control, but a girl who's going to school, any issues that you would want to think about?
2 times premixed insulin will be again.
Why do you think so, sir?
Because that will take the immediate glucose level also and the base
Yeah.
control also.
Okay, I think we'll leave it to Santosh. Do you want to?
As a doctor in us will tell us that the basal bolus insulin is the most scientific way to approach type 1 diabetes because of frequent episodes of not eating and then having hypoglycemia. But here comes a very practical problem. So after we do initiate with basal bolus insulin, we do shift many people to premix insulin because of this particular problem, the school. I know very big international schools who have nurses inside the school, but they are very scared of giving insulin in the afternoon.
Sure.
So most of the time our parent or the diabetes educator within the school needs to be educated from our side, and then they go on to administer. So we can take that extra step. But what about schools that we are not able to reach? Suppose a patient has come from a village and then goes back to the village. How are we going to manage in the afternoon time? So here the practicality comes more rather than the
Absolutely,
medical.
I take the point. And Dr. Prasanna Kumar, you've done a lot of work.
This is where I think we should all agree on one sentence. If there is one message at the end of this talk, the message is basal insulin is the most important in type 1 diabetic child. Whether you give 3, 4, 6, 8, I don't care at all. Again, what Santosh said is 100% practical. Again, you said the problem of Tamil Nadu giving insulin. If giving insulin alone can improve the quality of child, quantity of life, no child will die with diabetes. I am giving insulin 25 years. Till last year, every year, 2 child out of 100 are dying. In spite of providing insulin syringe, glucometer strips, school fees, uniform, name any damn thing, breakfast and lunch, even the bus charge also. Just giving that is not going to matter. Why this importance is, first is that you have to tell the parents whether sick or not sick, you have to give basal insulin. Even you give Mixtard twice a day does not matter at all. If the child takes 1 basal insulin, in the last 1 year out of 4,000 children from hundreds of ketosis, it has become hardly 1 or 2 because you provide insulin and basal insulin like that. And giving insulin without monitoring is just like driving at 120 kilometers on a highway with your eyes closed. What is the point in giving 6 vials, 20 vials when they don't monitor? When they monitor, they don't adjust it. It is just like looking into the mirror 3 times a day and you don't have comb to hair, or you are bald, you cannot comb at all. Why do you want to do that at all? So the question is, you do blood sugars, get back to diabetes educators or doctor who will constantly do this. If you don't do this, the whole exercise is futile. So first thing is basal insulin. Now his point is very clear. School, parents, nobody recognizes, no problem. We have started a new program in changing diabetes in Indian children. Last month in Belgaum we had one. Every month all over the country we'll have a program like know your teachers training, know your diabetic child well. Let us say you have got 10 diabetic children, they come from diabetic schools. Ask one teacher from each school and say, we will give half an hour, 1 hour talk about how to manage this diabetes. If the child starts eating in the class, don't punish because he is going to hypoglycemia. If the child has got hypoglycemia, give some glucose or something. If the child has to take insulin in the afternoon, give a separate room. You come to teacher's room, you can take injection and have breakfast. By doing it, even the poorest of the poor I am seeing, I said no question of premixed insulin. For all of them, use regular insulin and don't think that insulin analogs are better. No way. If I managed 25 years with animal insulins, last 10 years with human insulin, there is no need to give that, no need to give Mercedes-Benz. You have a better driver and Maruti car than Mercedes-Benz and bad drivers. So better you become good drivers, and that is what is important. And it is the compassion what you have, not the knowledge that you have got, not the academic publications what you have, that matters if you treat a child. Never miss the basal insulin, even if the child is very sick, is not eating the food, just giving that small dose. Basal need not be costly at 1,800 rupees insulin. Basal insulin is also NPH. Don't miss that at all. Even if the child is sick, simple NPH insulin, if his child is getting ketosis, will not occur. This is the importance, try to say. Don't use all these premixed, you cannot change. Use basal insulin and never miss basal insulin. That is the first insulin, never to be missed in child. Nearly 90% of ketosis can be prevented if they don't stop for any reason basal insulin. 24 hours or so, there will be some amount of insulin in the body to prevent ketosis. May not be sufficient to prevent the hyperglycemia or complication.
I think well said, sir. If there's one take-home message from this, I think this is what it is. You don't need to necessarily go for high-end insulins and all those loads. Just get some insulin on board. The one point I want to add is go low and slow. Don't rush too much of insulin first up and get the kid into hypo. And the last thing is patient education, school education, teachers' education is very vital. And just because the child is not eating and drinking because they're unwell, just get some basal insulin on board to prevent DKA. I think all very relevant points. I'll just give it to Dr. Ravi Kumar. Very briefly, with DKA, again, it's not something that the audience do it day in and day out, but it would be useful for them to get an idea.
A lot of protocols have come and gone. Now we follow ISPAD protocol, the International Society of Pediatric and Adolescent Diabetes, instead of the Nelson textbook of Milwaukee protocol. There's a lot of controversy about which protocol is better in preventing cerebral edema, but now no protocol, we know no protocol is advantageous than the other one, because we don't know what causes cerebral edema and what are the risk factors. So these children should be treated ideally in an intensive care setup with all the monitoring. And a very important factor is we correct the dehydration gradually over 48 hours. So that's the important message.
Thank you. Dr. Sundaraman, do you want to just add on?
No, I just want to keep you highlight that is there any difference of the severity of acidosis and the treatment? Is it definitely matters? Because we know that mild, moderate, severe. Now, if it really matters to you, the severity of acidosis and whether the bicarbonate is useful, then the severity of this thing.
The more severe the acidosis, the more higher the risk of cerebral edema, and which carries very high mortality, and more gradual the correction should be over a 48-hour period. And similarly, the bicarbonate we don't use nowadays. Use of bicarbonate is a known risk factor for cerebral edema.
Sure.
And also the association of pulmonary edema, just like cerebral edema, pulmonary edema has also been reported in pediatric practice.
Yeah, that is why we don't, we assume the dehydration to be 8.5%. We should never correct them more than 8.5%. Previously in Nelson textbook, we used a 10% correction, 12% correction, but nowadays we restrict to 8.5% correction, and that too we correct over 48 hours period. So that is very valid point to prevent fluid overload and pulmonary edema and resultant hyponatremia.
I think
Many of them do that. The children also, without their parents' consent, they take more insulin, go into hypoglycemia, so that they get more attention and they get more food, they get sweets. Every day the child, though I have written 6 will take 8 units, the child must will get hypoglycemia. Many times to gain attention of the parents and whatever the rewards, because in a house the discrepancy starts. The child with diabetes is treated with more attention, more care compared to non-diabetic child. That's why fictitious hypoglycemia occurs. Even many adults admitted to hospital, we go on investigating for the hypoglycemia, do all the tests. Finally, we found out there are some proof somebody has got insulin in the house. Even adults also do it with fictitious hypoglycemia as well.
I have got a different experience. I have got a few adolescent age group type 1 diabetes girls. They come to the hospital very lean, thin, like that. The moment you start them on insulin, they put on weight and good figure, and they are very happy to move around with the things. And they know with taking insulin they gain weight, and they get a feeling. They produce, they take excess insulin so that we advise lesser insulin. This one experience I have got, I thought I would just share.
That's a very interesting experience.
In fact, this eating pattern disorders are more common in adolescent girls.
Sure.
That is why eating, in Canada they published that even eating disorders are more common. So they need more attention.
Exactly. Yeah.
They take a lot of your time.
Sure. And
just 1 minute, sir. If I am not mistaken, the hypoglycemic awareness, it takes for years, not for an 11-year-old person. Because in that case, like when you are discussing on this, I don't think a 11-year-old child can get a hypoglycemic awareness, because it takes a minimum 10 to 15 years for them to have a sympathetic involvement in that.
Is it absolutely true, sir?
It is not. See, it depends upon
This is a real case scenario where the dose was jacked up quite a lot over the last 8 months. And that's just a real case presentation. I'm not sure whether there's any work done on how long it takes. But is there any...
President Master, is there any relevance of synthetic insulin producing more hypoglycemia?
What is synthetic?
Is it because of the structure?
That's what initially was thought, that human insulin causes more hypoglycemia. That is because when you were using animal insulin, we didn't have HbA1c, we didn't have monitoring, urine sugar, so blood sugar was never controlled. Once the human insulin came, then the younger generation started trying to achieve a good diabetes control. Then HbA1c came, everybody started to have 6.5. That is why in the last few years hypoglycemia has become more, and more studies have proved that whether human insulin or insulin analog cause more hypoglycemia with the same dose as the other insulin.
Sure. And just briefly moving on to role of oral agents in type 1 diabetes, particularly with metformin and with other agents. Santosh, is that something that you want to...
Metformin is something that we do add in people whose insulin requirement is going above a particular limit, because most of our population, they have a strong family history of type 2 diabetes and they have some amount of inherent insulin resistance in them. So once the insulin levels are going up and we are not able to achieve good glycemic control, we do add metformin in many cases of type 1 diabetes. There are some people who recommend the use of acarbose because it's not going to touch the pancreas. We find that the glycemic control becomes most brittle because we have insulins which act for say 2 or 3 hours, and acarbose is delaying it for even 3 to 4 more hours. We don't get a very predictable glycemic control with acarbose. Glibenclamide, no.
Dr. Ravi Kumar, quickly, I think this is the last question, so I just want all the
Sir, by adding in metformin, they are missing insulin. They are taking only metformin. That is another drawback. They think metformin is the drug of choice. Forget the insulin. Then you are losing the child.
Who said kids are easy, sir? They are very difficult. All of us would agree.
Metformin may have a role in obese adolescent girl, but in younger child, generally I don't use.
Sure.
We don't use any OHAs, as you said, for many of these reasons. And I don't believe most of them are most expensive, least effective. Insulin is the safest, cheapest, simplest, easiest, and the best. That too in type 1. If any OHA comes in future, that will be SGLT2 inhibitors in type 1. I think that is the only OHA which will be useful compared to any other thing, because it is not dependent upon the pancreas, nor it will cause hypoglycemia, and it is not dependent on beta cell also. It is likely to lessen the burden of pancreas.
The side effects, vulval infections, especially the girls, I don't, SGLT welcome, but the side effects of fungal vulval infection in the type 1 thing is maybe
something to be wait to be seen. Yeah.
Let's see. The treatment in the future will depend upon their molecular diagnosis. That's very important. Whether, as you know very well, Modi type, they can be managed with oral hypoglycemic agents. You know, I'm not talking about, I'm talking diabetes mellitus general in children, where it is, these oral agents come into play depending upon a molecular diagnosis. And what about your experience with refactorinide, which delays the gastric emptying? And there are some reports of using refactorinide along with insulin.
Sorry, in type 1 or type 2?
No, this is, I'm sorry, general, diabetes mellitus in children.
I think with that we have to come to an end. It's hypoglycemic. Apparently, last one brief.
Lifestyle. I'm very happy to have you here. The thing is about NPH. Sometimes, though some of us are vehemently against this under law, sometimes we may have seen that. The good news is that they had enough. So the patent is going to expire. The thing is, sometimes when individuals like me write that the insulin prices, insulin is brought up, when you people write together, so many things could be done. The thing is that it is easy for a company to bring everybody here, but for altruist purpose, it is very difficult. I get an email from you, do this, do this. Why not we sit and write something, try, this is what at least you people you do. You don't go behind them. You sit, you use your own pride. So many things to be done in India.
Good. Using our own brains, we'll definitely assure you that we'll go and do that. Thank you. Thank you very much. Huh? Yoga. I think this is something for the sidelines at lunch. Thank you very much. Thank you. Much appreciated.
I thank panelists for wonderful interactive session.